Bismillahirrahmanirrahim. We'll continue to study together, and this time the nasopharynx in English, as I have another one in Arabic. I thought it would be more useful to do it in English this time. The nasopharynx is one of the most important head and neck cancer nowadays, and I think the nice thing about the nasopharynx is that you can have a very good response rate and very high cure rate. Again, this is not kind of academic lecture. I'm trying to simplify things for my colleagues and highlight the most important and relevant information that we can put it in our mind and keep it there, and we'll never forget it. And trying also to simplify a few factors and few things like the radiotherapy, contouring, and some of the most important points in anatomy that we have to remember together. So yeah, let's start together, and I hope you will find it useful. To start with, when you open your book, you'll find the anatomy, and I think the anatomy we will talk together about it when we go for the radiotherapy part of the lecture. So it will be a separate lecture for the anatomy, but I think you need to familiarize yourself with the skull base foramina. So please go to the skull base foramina video and memorize it quite well, because we will use it extensively in the nasopharynx contouring. And the second point is I just want to emphasize is the lining of the nasopharynx, because sometimes you ask yourself, so most of the nasopharyngeal carcinoma are squamous cell carcinoma still, but the lining of at least part of the nasopharynx is by pseudo-stratified columnar epithelium, because it acts as a respiratory epithelium. It traps dust and like invaders when it comes through the nose. It's kind of a filtering as well, or a filter for our body and for our air. So one of the most important point in the nasopharynx lining and mucosa is that there is a junction line between the pseudostratified columnar and the squamous epithelium, and this structural or junctional line is in continuous dynamic changes, and that's very similar to the cervix cancer, when we called it the transition zone between the lining of the endocervix and the exocervix. So I told you at that time that there is a transition zone with continuous transformation and activity, and it's a common site of tumor formation. And exactly the same for the nasopharynx. There is a line of transition and active area where there is a chance for the tumor to happen, or the oncogenesis to happen. And again, this is also one of the bases for those who are against not to treat the rest of the nasopharynx. So there was kind of suggestion that we just treat the tumor with the margin and that's it. And against that are a lot of group of oncologists that they would say no, because there may be a field cancerization, and the lining of the mucosa is in a dynamic process, and it can push and can cause cancer in another part of the nasopharynx, and that's part of the recommendation that the whole nasopharynx at least should be covered by low dose radiotherapy when we will come to this point. But it's very important to memorize the skull base foramina. This is number one, and the second is you have to memorize, please, the lining of the nasopharynx, pseudostratified columnar epithelium, and squamous cell carcinoma. These are one of the most important points in anatomy. A second point I would like you to pay attention to is what we call the sinus of Morgagni. The sinus of Morgagni is a space between the skull base and the superior constrictor muscle. It's a space where the Eustachian tube elevator veli palatini will pass through, and the point for this sinus of Morgagni is a weak point in the nasopharynx. That's why it's easy for the tumor to spread through this weak point in the wall of the nasopharynx. So this is another important point. I would like just to arouse your attention to it. So for the anatomy, I talked about the epithelium, pseudostratified columnar epithelium, and we talked about the foramens of the skull-base foramina, and you will refer to the other video on this regard. I just emphasized the fact of the sinus of Morgagni, which is a defect in the wall of the nasopharynx, which aroused our attention for the easy spread to happen through the sinus of Morgagni deficient wall of the nasopharynx. Then the second point, when you study, you will see the epidemiology and etiology. And epidemiology and etiology is really interesting because of what we call it the salted fish story. In East Asia, Hong Kong, the fisher and the old there is all the traditional way of preserving the fish, and every time I ask myself, so what is the relation between eating fish and nasopharyngeal carcinoma? It's not passing through the digestive tract. And the point is, I found that when they heat the fish, the smokes of the fish will come through the nose and will produce, there will be a lot of nitrosamines on it. It seems like an interaction between the salt preservative and the fat of the fish or something of the proteins of the fish will produce the volatile nitrosamine, and we know that nitrosamines are carcinogenic. If you add nitrosamine to the presence of what we call it the Epstein-Barr virus together, this will be a causative or will induce or can induce nasopharyngeal carcinoma. Interestingly, that this salted fish tradition now is less and less common, and they used to wean their children on the salted fish, so it's not common nowadays to do that because of the changes in the lifestyle habit happening. But it is interesting to know the relationship between nitrosamines, salted fish, and Epstein-Barr virus as part of the etiology for nasopharyngeal carcinoma. Epstein-Barr virus, relationship between Epstein-Barr virus and the nitrosamine. Epstein-Barr virus is a very important virus, and we said before that the problem with this virus, although it is very common in other types of cancer like gastric cancer, Burkitt's lymphoma, Hodgkin disease, nasopharyngeal carcinoma here, still we don't have a clear vaccine or a successful vaccine for the virus, and this is the main issue actually for Epstein-Barr virus, I guess. I think personally, if phase 1 trial of the vaccine was successful, I think the team should get Nobel Prize, because Epstein-Barr virus is a common problem and it's really endemic and a big issue, a big problem in many parts of the world. So if we can get a vaccine for the virus, I think this will help to reduce the incidence and risk of many types of cancer. So Epstein-Barr virus is a very complex virus, and we couldn't do a vaccine for it, and it has a relationship between the virus and nasopharyngeal carcinoma is very well documented, and we found that as I am writing here, the DNA of the virus was found in the precursor cancer cells, and we found also what we call it when you read the book, you'll see the LMP. The LMP is a latent membrane protein, and the word latent is coming from being dormant. So like the virus can enter the cell and stay there when it starts to be stimulated, or the cells will be irritated, and that's why Epstein-Barr virus is synergistic, is working in synergism with the nitrosamines to develop the cancer. So that's a very serious relationship for the Epstein-Barr virus and relationship with the vaccine. The most important thing that Epstein-Barr virus is not now considered only as a etiology, but now we consider the number of copies initially. So if you see the risk stratification when we come for the staging. We will talk about risk stratification for the intermediate group for nasopharyngeal carcinoma, and we will say that the patients with more than 4,000 copy can be considered as at least intermediate high risk. And that's why the like initial assessment for the number of copies in the serum, I think this will be one of the investigation that we call specific investigation. We'll talk about it. When we say investigations, we have to divide it into routine, specific, and invasive, and we'll talk about it when we go for the investigation. So nowadays the number of copies in the serum is very important for the nasopharyngeal carcinoma induced by the Epstein-Barr virus. Interestingly, the human papillomavirus also may have a role in nasopharyngeal carcinoma. And there was a data coming from Hong Kong. They found around maybe among 7,000 patients that 7 to 10% of the patients were human papillomavirus or related tumors. But don't forget that some tumors of the oropharynx can extend up to the nasopharynx. This is a very important part. But we are talking about nasopharyngeal tumor per se that still can be HPV positive. And if it is HPV positive, it's not a bad thing. Actually, it's the response rate and the rate of cure can be as high or maybe better than with the Epstein-Barr virus. I guess it's even better than with the tumors related Epstein-Barr virus carcinoma. So it is not a bad thing, but I think it is important to be aware of it and don't be surprised with that. When you read in the book, you will see what we call genetic factors for nasopharyngeal carcinoma, and it's a bit, not saying difficult, but it's a bit tricky, and you need to just take it in a simple way. So they will tell you that there is nasopharyngeal carcinoma can happen in certain haplotypes, like patients who has a certain class of the human leukocytic antigen haplotype. What does it mean? Haplotype, just to start with, haplotypes are like group of genes that they will move in block, like group of genes together, they will be transferred to your children, for example. So they move in block, not separate. So if you have like a haplotypes, they are group of genes in our body that they will move to the next generation in blocks. So this is what we call it haplotypes. HLA haplotypes is a human leukocytic antigen. What you call it, I think the hematologist will know this better, what we call it the histocompatibility antigens as part of it. The human leukocytic antigens, they act like kind of a badge, like a badge on your cells to say something for the immune system. Like if you have a cell that will show us a signal or a sign or a badge on the cell, it will tell the immune system something. So we have two types actually. We have class 1 HLA and we have class 2 HLA. The class 1, the 1 go with inside check. So the I of 1 is class 1. So class 1 is I inside the cells. What does it mean? It's inside check. It's a check in all nucleated cells. Inside the cell, it acts as a guard. Look, oh, this is an infection. I'm infected cell. I'm now infected. How do I know that? Or how do the cell will know that it is infected or damaged? The cell will know by the class 1 HLA. Is it in a simple way? So if you have class 1 HLA, is like a tag, will appear on the cell when the cell will be infected or damaged. So this sign appear, or this signal will appear using the HLA class 1, a checker inside the cell. This check will be found by a killer T cell to kill the cell, what we call them the CD8 T killer cells. So the T killer cell will kill the cell based on the signal coming from the inside check. If you have an error in the HLA class 1 type, this can cause problem because the cell is damaged, the cell is infected, and nobody is dealing with it. Does it make sense? The class 2 is outsider. It's outsider. It's on the cells of the immune cells, and it gives us an idea about what is going on in the cell. So, for example, if there is a germ or invader, the immune cells with class 2 will engulf it, okay, and then will present it to the helper cells, say, look, there is something wrong going on there. Let's do something for it. Let's do a reaction, to react, do something. So it's a kind of another check as well. So the class 2 is a check, class 1 is a check, and remember that class 1 is inside check, class 2 is outside check. Class 1 inside check for T helper, and it's very sim for the T killer cells. The class 2 is outsider check for the helper T cells. What's the relationship between the haplotype HLA and nasopharyngeal carcinoma? It's an error in the HLA system and the human leukocyte antigen class 1. So they have a kind of special type of HLA antigen, and this is more than enough, I think. The second point that I found it interesting is that there could be also a genetic polymorphism in one of the enzymes that metabolize the nitrosamines. If you remember the tamoxifen, we talked about the CYP2A6. This is a cytochrome oxidase enzyme, one of the YP5045, I guess. But the same enzyme, we talked about it in tamoxifen, if you remember, can be present for our patient with nasopharyngeal carcinoma. They have a polymorphism to the enzyme that they cannot metabolize nitrosamine properly and can cause the problem of the nitrosamine with the virus, can cause the cancer. So they may have a genetic polymorphism as well, CYP2A6. Remember, for tamoxifen, we were talking that if you have a problem with the CYP2A6, the metabolism of tamoxifen to active form is not properly, will not happen properly, and can reduce the benefit from tamoxifen. Please review this. So I'm trying just to make things like linked so that we can remember it together. So let's summarize what we said. We didn't say anything. We didn't say a lot. We talked about the nasopharyngeal carcinoma. We talked about an information called pseudocolumnar epithelium and squamous epithelium. We talked about transition zone, which is an area that the cancer can happen on it because it is kind of into a continuous activity, very similar to cervix and the transition zone in the cervix. We talked about the skull base foramina, and you will check that. We talked about the etiology, importance of the salted fish and nitrosamine relationship, and why the vapor is a problem and what changes happen in social classes, and that's why the risk reduced as well. We talked about the fat in the Morocco, Tunisia, Algeria region, Maghrebian region. We talked about the genetic factors like the polymorphism or certain HLA haplotype, and we talked about what does it mean haplotype, what does it mean haplotype mean, what is the meaning of haplotype, and we talked about it as well. So this is, I think, or I guess that's more than enough. If you add smoking to it, if you add other diets, if you add anything else you find in the book, I think it's more than enough for you to know this information about the etiology and epidemiology of nasopharyngeal carcinoma. When you come to symptoms and signs, I think put lump in the neck, which is very common, and you can put it as kind of guessing. It's not a problem. Pain, like discomfort, epistaxis, if you want to put, change of the nasal tone of voice. But don't forget, please, ear pain, because we will add this to the causes of ear pain in patients with head and neck cancer. So if you remember in the lecture of ear pain and head and neck cancer, I talked to you about ear pain here in nasopharynx is not infiltration of the ear, is not it is only obstruction of the Eustachian tube that will cause serious otitis media. And obstruction of the Eustachian tube is very common because when we see the anatomy, we'll talk about the opening of the Eustachian tube just above the fossa of Rosenmuller, and it's easy for the tumor to compress and block the Eustachian tube. And if this to happen, this can cause ear pain, and sometimes we have to do myringotomy, or whenever you start the treatment, the patient will feel much better. So this is a very important point in symptoms and signs. Lump in the neck is very common in nasopharyngeal carcinoma, and maybe 90% can present with a lump without a large primary. And this is one of the silent areas of the of the head and neck cancer. So don't be surprised that you have an unknown primary and you take a biopsy from the nasopharynx and you find a tumor there. So this is a very important part of the symptom sign, but it is usually straightforward. We are trying just to emphasize the most important point. So the extranodal extension in imaging, what we call it IENE, is divided now into grades. And the grading now, although we're not radiologists, but we'll have to know it because it's reflected on the staging system. So if you don't know it, then you will not say it's ENE or not ENE, and you'll not upstage your disease then. So you have to be aware of that, unfortunately. So grade 0 is localized within the lymph node, no extra nodal extension. The grade 1 will be a bit of peri extension outside the lymph node in the fat plane, so it's a kind of extra nodal extension, classic. Grade 2 is kind of amalgamated lymph nodes together, like group lymph node attached to each other. Well, this we'll consider as grade 2. And grade 3, which is the most important one, because this will be reflected on the staging system, is infiltration of the muscle glands or neurovascular bundle. So this is a very important grading system. I never used to use it before, but now because of the staging of the stage 9, we will have to be aware of it with the radiologist when they tell us if it's a frank extranodal extension, is it extending to amalgamated nodes or is extended to the organ, and that's the importance as well of the MRI, I guess, because it's very difficult to decide about infiltration of the muscle, sternomastoid muscle, for example, without a clear MRI for the staging. So the staging is very important. Changes happened in the staging system, so please refer to stage 9. Don't forget to add the grading for the ENA. In the oral cavity, we talked about minimal ENE and major and minor ENE, but this is different here. So major and minor ENE was because of the size of the 2 millimeter, more than 2 millimeter, but here is different and has a clinical implication. So it's very important that you be aware of it. Unfortunately, it's additional information you have to be aware of. So this is what I was talking about. So we don't have any more in stage 3 disease. So it's now, stage 4 disease, only stage 3. So what was before stage 4A is now considered as stage 3. So this is a major change happened in the nasopharyngeal carcinoma. And also it has a clinical implication that you have to be aware of. So for the investigations, from the beginning, we said that any investigations will be divided into laboratory, imaging, and invasive. And this you can put it in the paper, like if you're writing essay question or answering question, or in the oral. If you are very systematic in terms of how you're thinking, I think you will never miss anything. So it's laboratory. We are talking about a routine and specific. Here, routine will be like the CBC, complete blood picture, urea, creat, blah, 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 blah. And the specific here will be the number of copies of EBVD, of the Epstein-Barr virus. So the copies, more than 4,000, has a very important predictive and prognostic vector for the recurrence. So if you have like a very high viral load, it's also an important information that you should be aware of. So before the treatment and the viral load after the treatment is a very important point. When you go to imaging, you go to routine and specific. And personally, I would say no nasopharynx without MRI. So because the extent of the disease and you use it for your radiotherapy. So MRI is very, very important in the imaging. If you want to add PET-CT, there's no harm. It's good. And other routine imaging is also important. Invasive, usually the biopsy, and if you have something specific like examination under anesthesia and pan endoscopy, for example, if you have an nasopharyngeal carcinoma or any other specific invasive investigation, you can add here, you can also put it. But being very systematic for any tumor site, this will help you a lot, I guess, or at least help me before a lot. Coming for the treatment, I think surgery for nasopharyngeal carcinoma, I would just leave it for the biopsy, excision of lymph node, or in the recurrence, like you have a neck dissection for a residual lymph node. I think this is the most important part. Nowadays, because of the advances happening in robotic surgeries, a lot of centers are talking about mucosectomy and resection of a tumor in case of recurrence as well. But I wouldn't put it up front in the in my answer. So I would keep it if I would like triggered to put it. So, but surgery for the nasopharyngeal carcinoma, we're talking about a biopsy, pan endoscopy, yes, take a good biopsy, yes, there's no problem at all. But for the primary lesion up front, I would be a bit keep it, not say it. I will keep it for the recurrence or for neck dissection in case of recurrence. So the role of surgery in case of in a nasopharyngeal carcinoma is a bit limited, and that's why as a radiation oncologist or clinical oncologist, nasopharyngeal carcinoma is one of your main sites where you are playing a very, very important role. For the treatment for nasopharyngeal carcinoma, a radical form of treatment is very, very simple. Because of the new classification, I think it's more kind of clearer for all of us that you can follow these guidelines. It's a very simple way. Before you go for the treatment, you have to go for the staging and know it by heart, because I will tell you that stage 1A, treated with radiotherapy only, stage 1A and 2 can be treated by radiotherapy only, or radiotherapy plus chemotherapy concurrently, and stage 3 disease, this is the one that will need everything, whether neoadjuvant chemo followed by concurrent chemo-rad or concurrent chemo-rad followed by adjuvant treatment. And then we will have to highlight few data and here and there, and that's it. So stage 1A, radiotherapy alone, which is basically an early stage disease with neck node negative. So by common sense, if no node, localized disease, early stage, that's radiotherapy should be more than enough. For the second stages, the stage 1B and 2, for intermediate stage 1B and 2, you need to put them into two categories. One is a low risk category and second is a high risk category. And the high risk category is very, very simple. It starts by 3 and end by 4. So there are 3 factors: start by 3 and end by 4. Start by a lymph node that is more than or equal to 3 centimeters, like a large node, because if you have like a small node, you are on the low risk side. So lymph node of 3 centimeters and above will put the patient into the intermediate high risk group, and this tumor can be treated by concurrent chemoradiation, and I will repeat it several times so that you don't miss it. For stage 1A, T1, T2, N0, no lymph nodes, treated by radiotherapy alone is more than enough. For intermediate risk stage group,
1B and 2, we need to escalate the treatment to concurrent chemoradiation. But in the same group, we are trying to be more selective. So for patients with a bit of a more risk, we will add the concurrent chemoradiation. If they don't have a high risk, then we can still use the radiotherapy alone. And we have data for this one, and I can share it with you. But just for the time being, you have to be so put it in your brain. I want to classify my treatment to be into classes. Radiotherapy alone, we are talking about stage 1A disease. Radiotherapy plus chemotherapy, I will add chemotherapy to the radiotherapy in case that 1B and 2, which is the intermediate stage group, they have some of the higher risk features. Lymph node more than 3 centimeter, extranodal extension, and EBVD more than 4,000 copies per liter. And this is why we added in the investigations the ABV copies and also the extranodal extension. And here is why we added the grading system for the extranodal extension, because if I tell you I have an evidence, a radiological evidence of extensive advanced extranodal extension and involvement of the adjacent structure, what we call it ENE grade 3, as we talked about it earlier, then this is an N3 disease. This is a disease that will go to stage 3, so this will be an advanced stage disease. But if I'm talking about like some extranodal extension as grade 2 and grade 1, you may consider the patient into the concurrent chemoradiation only and consider him as, or the patient as still not like an N2 disease without advanced extranodal extension. So this is very important. So we paved the way for the treatment just by knowing the investigations with the copies and by knowing the classification of the extranodal extension, because it's very important part. As you can see here, we are basing our treatment, we are putting our treatment based on the classification of the high risk category for the intermediate stage group. I hope this is clear. So 1A radiotherapy alone, 1B and 2 low risk radiotherapy alone, 1B and 2 but having some high risk features, you can use concurrent chemoradiation. So this is a very, very important classification, and this is how you put it in your brain. And then go for the advanced stage disease, which is called stage 3, and it's a very simple term, N3 T4 disease, and any TN3 or any T4, and then you have to go back and know exactly what does it mean N3 disease. And don't forget that N3 disease is an advanced radiological extranodal extension. N3 disease is advanced radiological extranodal extension, in addition to below the caudal border of cricoid cartilage, in addition to more than 6 centimeter in greatest dimension. And by the way, any of these factors will put the patient into N3 disease. So we don't have to have it all 3 categories, okay? So if you have like a lymph node more than 6 centimeter, if you have an extension below the caudal border of the cricoid, if you have an advanced radiological extranodal extension, this is all together will put it into the N3 disease. In T4 disease even, there is a very interesting part when they said like orbital extension. In the past it was like orbital extension. Now if there is an extension to the inferior orbital fissure, we'll consider it as T4 disease. So please review the staging. I'm not in a process of like a full academic lecture, as I said, but I'm just highlighting of how you can tackle the information and understand it properly. So please refer to T4, NEN, N3, NET disease, and then to the stage 3 disease we'll have to treat by everything basically.
There is only one problem that you may come to your mind. We are talking about intermediate stage 1B and 2 and low risk and high risk, but you must have the question in mind that you are telling me that the copies is more than 4,000 copy per liter. So what about a nasopharyngeal carcinoma that is not ABV positive? So that's a very crucial point, because we know that the non-ABV related cancer are more aggressive. So I would rather be careful with that, and I would tend to be towards the aggressive side, so the concurrent chemorad side, rather than the radiotherapy alone side. And I think just be careful here, because when we talked about the risk criteria, the data coming from the endemic area, the data coming with a risk stratification stating that a patient with copies more than 4,000. So what about if it's a non-EBV? What should we do then? Then this is a very important point you have to keep in mind. I would rather treat them with concurrent chemorad rather than radiotherapy alone. But I think we need more data about it. So this is a very crucial point I just wanted to mention. Then you have the advanced stage of the disease, and this is the point where you have all discussions about the induction chemo, followed by concurrent chemo, followed by the adjuvant setting. So just to make it very, very clear in your mind, what should we do? First, if you want to have a clinic, if you have a clinical trial, it's good to have the patients in a clinical trial. But if you don't have a clinical trial, you should know what is the standard of care for this group of patients. And the standard of care for this group of patients will be induction chemotherapy, followed by concurrent chemoradiation. The data mostly used for the concurrent is the 100 milligram per meter square, which is a very important point, but I don't mind at all using the 40 milligram per meter square. For the induction, you have also different chemotherapeutic agents that we have data for. The commonest nowadays is the gemcitabine plus cisplatin, because of the it's easy to use, and you don't need the PICC line, and you don't need the pump used for the 5-fluorouracil, but it is gemcitabine cisplatin as first choice for me, and I think for most of the oncologists nowadays. Again, you have to be aware that it is mainly for the EBV viral positive patients. So this is the data coming from the EBV virus positive patients. The second is what we call the TPF, but the TPF used again for the EBV virus positive patient was a low dose TPF. So it's a TPF with 660-60. What does it mean? 600 milligram per meter square 5-FU, 60 milligram from the per meter square cisplatin, and 60 milligram per meter square docetaxel, and the 5-FU was given over 5 days. So the first choice cisplatin gemcitabine. The second, you have also the TPF, and the TPF is a modified type of TPF, and some of the experts raised the concern that maybe it's weaker if you use it to the non-EBV virus positive patient. And the last is the classic cisplatin 5-FU. If you felt like that gem is not suitable, or you felt like the TPF is not suitable, and you want to give a cisplatin 5-FU alone, it's also a valid option, although it's not the preferred option nowadays, because we know that, or that we have the data supporting that gemcitabine is superior to the 5-FU cisplatin. So we have two superior regimens and another third one that you can use. A very important point here I want to add, please, when we say this is the standard of care, when we say that neoadjuvant chemotherapy followed by concurrent chemoradiation
this is a standard of care, you still may have a patient that you feel, and this is need a bit of experience and a bit of judgment, you may have a patient who you would feel that he will not tolerate this intensive type of treatment. It's a very aggressive treatment. You give neoadjuvant followed by concurrent. So sometimes you feel, no, I would say if this patient can maintain his fitness for the treatment, he may tolerate the concurrent only. So I wouldn't deprive the patient from the concurrent for the sake of the neoadjuvant. Does it make sense? So what I want to say, or the message I want to deliver, is that for advanced stage disease, you can still use the concurrent chemoradiation first upfront and avoid the induction if you feel the patient is not fit enough for the induction, and you just reserve all patient power and function to tolerate the concurrent chemoradiation that can still lead to curative treatment. Clearly, the patient, if he's not fit enough to take the induction chemotherapy, he will not be fit for the adjuvant. Hope this makes sense for you. So, because one of the options is to give the concurrent and give the adjuvant, but the reason why we switched to the induction, because tolerability for the induction is better, and we have now data to support the induction chemotherapy in terms of survival advantage, and compared also to the adjuvant setting. So we all now use the induction because of the data supporting it. The adjuvant can be used, there's no harm, because of the data from Al-Sarraf, the intergroup trial long time ago showed survival advantage. But the problem is that after the concurrent, majority of our patients may not be fit enough for the adjuvant. That's why we switched and shifted from the induction from the concurrent to the induction chemotherapy. I hope this makes things clearer for you. The data, I will not discuss all data here because it's not a scientific kind of lecture. I just want to put things in order for you. So we have stage 1A, we have radiotherapy alone. Stage 1B and stage 2, we have a high-risk group and intermediate and low-risk group. The low-risk group, provided it's an EBV virus positive, you can treat by radiotherapy alone. The high-risk group containing, or they have one of the risk factor, a lymph node more than 3 centimeter or equal to 3 centimeter, copies of the virus more than 4,000, and extra nodal extension, but not the extensive one, because the extensive one will move the patient to stage 3 disease. There is a lot of other factors and discussions that we can put here, but I don't want to make it a very bad lecture, honestly. But I just want to make things clearer first, step by step, bit by bit. Everything is now in order, and then we can add on top of it. Now, if everything in your mind very clear, then you can add some extra information, so bits of small information, something like, should I use carboplatin or cisplatin? I think we will all use cisplatin, but still you can use the carboplatin for certain group of patients with hearing problem, or you would expect some problems for them to happen from the cisplatin, peripheral neuropathy, things like that. Then you can use the carboplatin still, but we don't have enough data to support its use in the routine practice. So this is an important point. A second important point nowadays we're talking about is what we call it the adjuvant capecitabine. The adjuvant capecitabine. So the adjuvant capecitabine can be given in the form of 6 cycles, or we have also data to support metronomic capecitabine. Metronomic capecitabine. Metronomic means that you depend on the time. rather than the dose. So you take, like, you give the patient small doses every day. Usually it's around the 650 milligram per meter square, and you give it every day, rather than in the form of courses, large doses over like 14 days and 1 week rest. This is what we call it the classic dose of capecitabine. But the metronomic one is giving daily doses and can extend up to 12 months. This is the adjuvant capecitabine. The adjuvant capecitabine in nasopharyngeal carcinoma showed survival advantage in the form of disease-free survival advantage mainly. But nowadays there will be a question about which patient would benefit most from this adjuvant capecitabine. And again, here where the copies of the virus and the viral load can come. If the patient had no residual EBV copies found, then maybe he will not benefit. And we are trying now to select some group of patients with aggressive type of tumors that will have remaining EBV activities or EBV residual like copies of the virus, and this will lead to like a high risk of relapse, and then you select them for the adjuvant capecitabine. So it's something that is now under consideration. Just to be honest with you, the nasopharyngeal carcinoma in the exam is more common to come in the recurrent cases. So recurrent and metastatic nasopharyngeal carcinoma may be more important than all what I was talking about. But the problem that if you don't know what I'm talking about, you will not be able to treat a patient in the recurrent case. So that's why I have to start with the radical and primary treatment. But to be honest, in the exam, you have to be ready for the recurrent cases. And the reason why, because recurrent nasopharyngeal carcinoma treatment contain basically everything. The question can include brachytherapy, can include stereotactic radiosurgery, can include VMAT treatment, can include chemotherapy. You can start by chemotherapy first, chemical site reduction, and then followed by an aggressive local treatment. You can consider surgery, endoscopic mucosectomy and resection. Some surgeons, they are very aggressive. They do open resection for residual diseases or recurrent cases. So recurrent, now we have the immunotherapy as well in the recurrent cases. So the recurrent case story and metastatic setting as well, immunotherapy. So the current case story in nasopharyngeal carcinoma, I usually personally recommend that when you finish treatment and you finish discussing everything, this is the bell, we have to stop. When you finish your treatment and you study it by heart, you have to at least once you have to start from the back forward. You have to start by recurrent cases, and because this is a very important topic in the exam, and as I said, it has a lot of skills, a lot of things to be discussed, whether oral or whether written. And it's very common in Egypt, by the way, to discuss, to have a question in the exam with recurrent cases of nasopharyngeal carcinoma. So now close your eyes, okay, and let's remember or try to remember what we said. We talked about a start in the anatomy, yeah, and we said that most important point in the anatomy is pseudostratified columnar plus squamous transition zone area of high risk of malignancy, and there is a theory of field cancerization. Second point in anatomy, skull-base foramina. You have to refer back to the lecture, because in the next lecture we will have to go for the planning system and start to contour a case. And the second point the third point in the anatomy is the sinus of Morgagni, where it is a weak point in the wall of the nasopharynx, where the Eustachian tube and the levator palatini coming in, and there is a weak point, and this is easily can be penetrated by the tumor. In the etiology and epidemiology, we talked about the salted fish and how the salted fish can produce nitrosamines, and volatile nitrosamine will go to the nasopharynx, and nasopharynx there is an EBV viral latent protein setting there, can produce the cancer. Latent LMP, latent membrane protein, we found it in the cells of the nasopharyngeal carcinoma, and we know that Epstein-Barr virus is a very important etiological factor for nasopharyngeal carcinoma. We are waiting for a vaccine, phase 1 trial. I'm really wishing that they will succeed in doing it. We talked about the EBV as a prognostic factor in terms of copies, and we added the EBV in the investigations, or what we call specific type of lab investigation. We also moved to what we call it genetic factors, the HLA major histocompatibility complex, HLA type 1 classic, as what we call it a GARD, and class 2, which is also kind of a signal for the cell there is something wrong, and as if it's a label on the signal. One is internal to cause cell death, and second is external for a reaction or an action to be done. We talked about that if you have a first degree relative with nasopharyngeal carcinoma, you may be having also nasopharyngeal carcinoma, and that's why screening program can also work in there, and some would suggest it. We talked about symptoms and signs, and we talked about ear pain, and obstruction of the Eustachian tube can cause serous otitis media, and we talked about the signs, and lymph node in the neck is very important. I think we forgot to say that cranial nerve affection is very, very important in nasopharyngeal carcinoma, and I would personally put a failure mark if you forget to examine the cranial nerve in any patient with nasopharyngeal carcinoma. We talked about investigation. We divided the investigations into laboratory, routine, and specific. We talked about imaging, routine and specific. We talked about invasive, routine, and specific. We talked about the treatment, and we said that surgery has a limited role, although it may have a role in the recurrent disease, but don't forget that it is in the recurrent disease and can also work in neck dissection. Don't forget that part of the panendoscopy will be done by the surgeons. For the treatment, we have to go for the staging first before we go for the treatment, and we said that the EJCC9 changed the staging completely into stage 1, 2, and 3, and even the metastatic setting stage 3 became M1A and M1B, less than 3 metastases and more than 3 metastases. The staging for nasopharyngeal carcinoma, we divided the group into stage 1A. This is early stage non-negative. Radiotherapy should be enough. For stage 1B and 2, we talked about a group called high-risk patients, and these high-risk patients are patients with certain factors. They are 3 factors, started by 3 and ended by 4. More than 4,000 copies, more than 3 centimeters, and in between ENA. ENA, there is a grading for the ENA that you should be aware of. The ENA, grade 0, grade 1, grade 3. Grade 3 will be classified as N3 disease. So grade 3 will be classified as N3 disease. Very, very important. The low-risk intermediate group can be treated by radiotherapy alone, with a question mark from my side saying I would do it for I will not do it for non-EBV positive patients. For stage 3 disease, T4NAN, N3NET, those will have everything. Induction chemotherapy followed by concurrent chemoradiation followed by adjuvant chemotherapy. And we said why we don't like that. Concurrent chemoradiation alone is not a bad choice, by the way. Don't ever think that you are compromising your patient. No, you are doing a good thing for him. You are very well judgment. You have a good judgment, and you are choosing your patient in the right way, and that's why you treat it by concurrent radiation alone. And finally, we said that after the concurrent chemoradiation, we may have a group of patients we may think of adjuvant capecitabine, whether it is a metronomic type over 1 year period or in the form of 6 months of treatment. And the way 6 months is because it will end up by 8 sessions, by the way, every 3 weeks, once every 3 weeks. So it's a kind of 6 months of treatment. We said something about the recurrent cases. This will need a specific lecture, by the way. Recurrent cases in nasopharyngeal carcinoma is very, very important because it has all skills in one place. The metastatic nasopharyngeal carcinoma can be after the treatment or can be upfront, by the way. We didn't mention that, but I would treat the patient with upfront limited disease metastatic squamous cell carcinoma, nasopharyngeal carcinoma radically. And this is one of the few cases where in the metastatic setting I may go far beyond for the treatment. So I would go for chemo first. A very good response, I may push more by concurrent chemoradiation and treat as a radical treatment. And also we can deal with the metastatic lesions by maybe stereotactic body radiotherapy. So I think maybe the metastatic and recurrent, we can put it in a separate lecture if this is okay with you. So I hope this is to summarize for you in a very simple way what we said today, and I'm hoping that it will be easy if you are in your car or you can listen to it, and I'm hoping it will be useful for you. Thank you.